My name is William Hong. I'm one of the neurologists at Both and Boston Center of Excellence in CDKL5. In this session, we'll be talking about prevalence and description as the behavioral challenges in CDKL5 deficiency disorder. We'll talk a little bit about behavior and medical evaluation, what causes some of these behaviors, and then we'll also touch upon the treatment aspect, pharmacologic and non-pharmacologic, both are equally important. Dr. Kim and I don't have any disclosures. I should say I am not a psychiatry per se, but I have a lot of interest in behavioral neurology. I do work in the autism center when I'm a little bit when I'm not in the CDKL5 clinic. And I think the involvement and then some comfort level neurologist in assessing and managing some of these behaviors is important because we often serve as like the child's like medical home and usually in collaboration with the pediatricians. And then but we are probably the most important advocate along with the family. And then also help bridge them to specialists when it's necessary. So in CDKL5 deficiency disorder, we know that global developmental delay is very most common symptoms. We had a session on seizures and epilepsy management earlier, but there are other symptoms like GI issues, speech, and behavior, vision. Behavior is quite up there when we survey the families and caretakers about what are the top 3 most burdensome symptoms. And they're described as, using terminology as like irritability, agitation. These are like tantrums. They're hypersensitive. They have aggression, self-injurious behavior, as well as some perhaps maybe a little bit more tolerable milder symptoms such as stereotypy and bruxism. We are also learning that behavioral challenges can be more common and more severe in those who have milder CDKL5 deficiency disorder. Dr. Olson's study, Expanding CDKL5 deficiency disorder, EXCEED, looks into children who have milder degree of CDKL5 disorder, specifically those who can walk, who have some expressive language skills, and who have like fine motor skills, and then also those who have good seizure control under no or one medications with good EEG background. And then when we look at the symptoms and phenotype, they're described in these milder children with CDD. We are noticing that a lot of in those who have good motor, gross motor, fine motor, and language skills, the caretakers and families are reporting more severe and more common behavioral difficulties. They are described as like screaming, throwing, pushing. They're anxious. They're hyperactive. They're loud. They can be also sometimes be aggressive, headbanging, getting on the floor, bad meltdown. So these are real symptoms that should not go under-recognized, and they're often kind of triggered by some sort of a task demand, changes in routines, new sensory stuff like noise, and we do know that it takes a big toll on the family. So families can report they feel really isolated. They cannot go outside. They can't do things spontaneously, and then they describe there as like really hectic and exhausting night, and then particularly with in the setting of like hyperactive aggression, impulsivity. There's also a parental concern for safety, legitimately. Yeah. But we do know that our children with CDD can be very happy, kind, lovely, they're affectionate, they love others. They're also lovable, very sweet. So, like, where do this behavior come from, right? So when we think about where do this behavior stem from, then we think about like three large pillars that we need to assess. So medical evaluation, especially when things are like acute and new. Is there something going on medically that is causing our kids to be feeling uncomfortable, manifesting in behavior tantrums? Is there changes in the environmental factors that are potentially modifiable if they can be identified? And then both medical and environmental factors can kind of fit into your child's like underlying risk and disadvantage they may have from the underlying genetic condition, CDKL5 deficiency. But even in those outside of CDD, like neurodevelopmental disorder, they are at higher risk of like having difficulty with communication. They can really express things very well. And they often have sleep difficulty. So when you and I don't sleep very well, we tend to be a little bit more irritated than usual. And then is there like other, not necessarily a disorder, but some like a spectrum of ADHD, attention deficit, or anxiety trait, or autism spectrum disorder has a or spectrum in there that can make the child a little bit more sensitive with emotional impulsivity, fight or flight response, and sensitivity, rigidity that we see in autism spectrum disorder. So it's important to evaluate all of these in a comprehensive manner when we're dealing with behavior that are challenging and they're changing. So if we go back to the initial slide of the burdensome symptoms that we see in CDKL5 deficiency disorder, I want to make sure that texts are large enough. Yeah. So it's important that we do like comprehensive review of systems. So seizures can, to some children, be irritating. Epileptic spasms, we do know that between the spasm cluster, they can feel like irritable. Some children who has other type of seizure, after the seizure, they can feel irritable out of it. They can become sleepy, which can affect their mood. GI symptom is a very common trigger. So, and we already know constipation, reflux, air swallowing, those are all things that can happen as a GI manifestation of CDKL5 deficiency disorder. So is there any worsening from it? Or it's been kind of stable, but at some point it kind of hit the threshold. Visual impairment is also a very common issue that can be a trigger. So cortical visual impairment, if you cannot see very well, you may not be able to recognize your environment very well. Things may come to you very quickly, fast, and may be surprising. If you have allergies and you rub your eyes and you have something in there and it didn't go recognized, you have like corneal abrasion that can cause pain and discomfort. And then certainly other factors such as tone. So those, if you have spasticity or like your muscles are tight, and then it puts you in like a abnormal, uncomfortable posture, that can certainly be a factor. Respiratory and sleep issues. If you have a upper respiratory infection and you can't breathe well while you're sleeping, and if you on top of that have obstructive sleep apnea, then your sleep quality will be very affected. And are you having difficulty sleeping just in general? Do you have trouble falling asleep? Are you waking up a lot and overall disrupt your sleep quality at nighttime? Along with the parents, unfortunately. And then if you move down to the bottom, like other like ear, nose, and throat, like are we dealing with like cavity, central pain, ear pain, sinus infection, urinary tract infection in girls, menstrual cycle in adolescents, girls, and we also need to think about like doing a review of our medications, because some anti-seizure medications, you can have paradoxical reaction. Even some mood medication, you can definitely have a paradoxical activating effect. So those all need to be like comprehensively reviewed. And then what are the other like environmental factors that should be assessed? So did the family just get a new house and move, or did the sibling went to college and then now no longer living in the house, or is there temporarily like conflict between mom and dad, and is that upsetness is kind of overflowing to the child? Is there changes in school environment, new schedule, new building, new staff? Sometimes there's a lot of turnovers in school staff, and that kind of goes unnoticed, except for your child. And then any changes in your therapist. Overall, like, are there any factors that result in increased task demand, more changes? We all do well with like routines, but some children are more sensitive to changes in routine. And then are there any like new type of stimulation, like noise, texture? And we also certainly have to also need to like think about what are some unintended way that we are like unconsciously reinforcing these behavior. So if you can identify a trigger, what action do they take? And then after the action, what happens? Do they get the attention they haven't gotten? Do they get some sort of reward? Or are they able to escape from a task demand if they become irritable? And then they will learn that, oh, if I do this, I get to escape, or I get this. So they can sometimes be served as like a reinforcement factor without the caretaker and parents realizing it. So then if you do recognize them, like what do we do? Like, can we plan things a little bit better? Can we make a visual schedule so that it's up there all the time so that they have a better understanding of what's next? Can we provide them with choices, better communication method? And then if we think that there are some behaviors that are being reinforced unintentionally, how do we get around that? We often, can we ignore those behaviors and not like reward them or allow them to escape from the test they want to get out? We often take positive behaviors granted. When they're doing good things, we just let it happen. But can we like pick up on those and then reinforce those positive behaviors, give them a lot of praise? And then, yeah, as long as we do this while keeping the child safe, that's the red triangle. We certainly don't want to ignore behaviors that are unsafe. So those are all things that we also need to think about. But then in reality, you may not find a trigger, or it may take a while until you actually find a trigger. So then we also think about like, oh, what are my child like risk factors? Like, do they have something comorbid, like other common, not just CDD, but even in like general population? Do they have like ADHD like symptoms? ADHD has attention deficit hyperactivity disorder in the name, but what's not written in the name is they also have a lot of impulsivity, including emotional impulsivity. Anxiety, like we know that anxiety is an important part of life, but when it gets extreme, then children can go into like a fight or flight response, 0 to 100 really quickly. And then autism spectrum disorder, which is a spectrum disorder, but they can have a lot of sensitivity, rigidity to changes. And then as they get older, as our children reaches like adolescent and young adulthood, and that's when like symptoms of depression or bipolar disorder can manifest more compared to ADHD, anxiety in younger children. And then depression in those who have like communication difficulties can manifest like differently from like our typical depression, where you feel sad, but they may not be able to express that sadness. They may just look a little flat. They may be withdrawn, irritability. change in sleep, eating pattern, not a single point here is diagnostic of depression, but you can, if you meet a lot of these criteria, then you have to start thinking about depression. And if there's a cycling nature of periods of feeling really depressed, and then followed by periods of feeling really elated, then we also have to think about like bipolar disorder. So all this to say, it's important that we have like good close relationship and collaboration between neurology, psychiatry in order to like screen and then provide them with appropriate help and management plan. And I think that's a good way for me to segue to Dr. Kim, who is our amazing psychiatrist, who will talk a little bit more about some therapies and treatment.
Hi, everyone. So within psychiatry and neurodevelopmental disorder clinic at Boston Children's Hospital, I specialize in psychopharmacological intervention of behavioral challenges, and I work with anyone's family with autism, developmental disorders. Obviously we have kids with CDD. So I before I start talking about any of this, I wanted to kind of share that it's every year I feel very humbled, having more and more experience working with the families. Especially I learn a lot from their perseverance and patience, and I always share with the families that I can't really do much without them, and I'll share why. So these are some of the basics. There's evidence that the addressing autism-like features in CDC, of course, is applicable. There's benefit for ABA. Like Dr. Hong mentioned briefly, there's focus on functional communication training, reducing maladaptive behaviors and building adaptive skills. Similarly, OT, PT, there's a database report that there's been benefit from PT and OT in the CDD patients. Motor planning, sensory processing, etc., and sensory integration. Again, the ABA can be a really wide spectrum, and generally I do welcome any behavioral approaches that could help us identify the triggers and hopefully reduce the triggers or reduce the maladaptive behaviors without having to go to the medication routes, which doesn't necessarily mean that we shouldn't consider medications. They could help each other. And again, briefly on the AAC, most individuals with CDC have little or no speech. And, the caregivers report different ways of mode of communications, vocalizations, facial expressions, eye gaze, and body movements, and aided devices. And again, this is one particular, place where I'm really amazed by the caregivers, how they really learn to pick up signs of distress or discomfort. In particular, I have a family that I've been working with their child, whom we diagnosed as bipolar disorder. None of the diagnoses would have been possible if not for families' persistent efforts to pick up the signs and symptoms. And I often tell the families, I'm not a mind reader. I can't really do much of what I'm doing without them helping me see what I need to see. So AAC does not prevent or limit acquiring verbal language, which I often repeat to the family because they sometimes worry that would it hinder the language acquiring. And there's really no prerequisite to AAC evaluation. All individuals with a severe communication needs should be offered. And also the families could utilize vision consultants. We often recommend that should be part of the education team. Again, the key point here is, as with any behavioral challenges, whether it's a CDD or autism or any of other cases that I deal with, other sectors of child psychiatry, unmet communication are the main driver of any sort of challenging behaviors. Even if you have a teenage, daughter or son who doesn't have any of the psychiatric issues, you'll know what I'm talking about. So improving the mode of behavioral communication or the communication of their needs or psychological needs or behavioral needs, it's really the cornerstone of improving their behaviors. So sleep disturbance is very common. The number shows about 87%, and it's definitely a major contributor to daytime behavioral problems. We know, for instance, if your child has ADHD, if their symptoms of ADHD will be much worse after a bad night's sleep. We all know how we feel after 1 or 2 nights of bad sleep, right? And then imagine our kids have chronically bad sleep, like not just a week, a month, and years. You can't expect them to be pleasant, right? So this is never, it can never be overemphasized, but unfortunately it's not an easy target to treat. So obviously, although it's a boring repetition, good sleep hygiene is very important. Studies over and over in any sector of psychiatry show that sleep hygiene is the most important. Again, I know it's always easier said than done. I've met so many families that do absolutely perfect sleep hygiene, still have a lot of challenges. And we can consider sleep medication options, which I'll discuss a little bit later. I want you to pay attention to the bolded words. I was digging up the literature just to prepare these slides. Again, which I have been aware, but I was again humbled again by sort of absence of any clinical trials that's specifically looking at the treatment of behavioral challenges in CDD population. Even in cases like autism or IDD, it's not too much better. I mean, we do have studies, but the number or this or the volume is not anywhere we want it to be. This is partly where I'm really humble, and I always remind families, we know what we know. We're still going to do things that we know from other studies, which I will mention here. As you can see, another bolded word, extrapolated from existing studies, like say, studies that looked at kids with autism or other types of developmental or intellectual disabilities. So we are trying to base our interventions on some data or information, but we should also be very humble that there's no specific clinical trials. So I always try to make sure that we really have a good reason to go for medications. And then it's not always the distress of the behavioral, that distress that causes the behavioral challenge, but also the distress resulting from behavioral challenge. And I always make sure, this is probably one thing I really, really make sure in my practice, is the stress on the caregiver. As you may have heard or experienced, a lot of caregivers feel guilty about having to medicate their child. They feel powerless. Hey, I said I should have managed it better, and why do I have to medicate my child? But I always try to listen and make sure they understand where I come from, that hey, your well-being, quality of your life is very important. The more you love your child, the more that's important. More important is your mental and physical health. So so I always try to make sure we have a really good reasons. Again, let me repeat, the goals of the treatment will be improving the quality of life for the child or the adults with CDD, also the caregiver. They're very important altogether. And we do want to make sure we have a target. If you don't know what you're targeting, it's going to be very confusing in terms of what helps and doesn't help. And we try to go after, we try to make sure we assess to see if there's any diagnosis, but a lot of times it's hard to or impossible to diagnose. So then we have to go after a symptom or a sign, and then again, it has to be specifically set as a target. And the key principle I write in textbook, and I always share with my families and caregivers, is to start low and go slow. Any medicine we do, with or without specific evidence, I always say we start low. And how low? And this is something I get asked a lot by my colleagues. How low is, what do you mean how low, right? So typically my rule of thumb is that if a medication, let's say the smallest tablet is 5 milligrams, I'll ask parents, how small can you split? They'll usually say, well, half is reasonable, quarter makes it crumbs. Like I tell them, don't worry about the crumbs, it's small enough, but smallest, if it's tablets, if it's liquid, it's easier, right? But we know some of our kids don't like the texture or the taste of liquid, so we try to stick with the tablets. But that's the rule. There's no more magic formula. And so let's say if a medicine guideline is like start at 5 milligram, I'll tell family, let's start quarter of 5, at least about a week or two, just to test the water. Because if there's going to be any side effects or adverse effects, it's easier to tolerate if we start low, So instead of going at a regular starting dose and go up faster, I'll usually say let's start extra low and step by step. And each time I educate the family, if there's any side effects with a new dose and they know, go back to the previous dose, right? And then it's absolutely important, sorry I didn't write it here, is that just one medicine at a time. Despite the sense of urgency, no matter what, don't make more than one change. So let's say I'm collaborating with neurology, Dr. Hung here, and I'll ask if Dr. Hung is adjusting their seizure medicine, I'll tell them, don't bother with any of the psych medicine. Let's hold everything else, same thing. Like I ask them even to not change any of the over-the-counter medication they're doing because there are too many variables. The only way we can tell is to be consistent. Again, we're for our kids with developmental disorders, autism, CDD, IDD, we're always fighting against the odds of side effects, or more correctly saying adverse effects. So it's very important. Whenever a behavior is presented, especially with a new medication trial, I spend a lot of time with the caregivers discussing, is there a possibility this is a side effect or adverse effects of medication, right? That we look at the timeline, try to review. Sometimes the only thing we can tell by is to go back and see if it reverses it, right? And minimize polypharmacy. This is always a big concern because our children or adults with the CDD often have other medications. Polypharmacy is not always evil. Sometimes it's required. But in my definition, the polypharmacy is really just more about not just the sheer number of the medication. It's more about giving redundant medication. That's what I'm trying to avoid, right? And then monitor for paradoxical reactions. Well, what paradoxical reaction means that, hey, you're giving a medicine to make them more relaxed. If they seem more anxious, more nervous, more restless, that's the paradoxical reaction, right? It could always happen, especially, you hear about the medicine like benzodiazepine that is supposed to calm them, right? But they sometimes get belligerent, right? So that's a paradoxical reaction. If any medicine is known to have a paradoxical effects, more likely than not, I go extra slow, extra small steps. But unfortunately, that shouldn't, unfortunately, or fortunately, that shouldn't preclude the trial. If, let's say, a kid condition requires a benzodiazepine trial despite the known risk of paradoxical reaction, you can still make a rationale to go forward, but you just have to be extra careful, okay? I was debating whether I should go by the specific medication class or symptoms or diagnosis. I decided to go with the symptoms because I think that's how parents often wonder about, right? So anxiety, obviously most common disorder or symptom. I think of it as, our children with autism, IDD, CDD, or other developmental disorders, the way they look at the world, they perceive the world is very different from ours. And you have to understand there's a lot of anxiety involved. And so this is a very common symptom. SSRI is always the first thing that comes to our mind because it's the most established antidepressant, anti-anxiety medication in psychiatrists. There's some preclinical data with the animal model that show sertraline, brand name Zoloft, may rescue autistic-like features, stereotypies via serotonergic pathway. But of note, no human trials, and a lot of the preclinical data, unfortunately, especially in psychiatry, don't always translate into, the in-human trials. So we have to be very careful. But it sheds some hope, of course, for helping us understand what may be underlying. And SSRIs, unlike many people actually know about this, do carry risk of seizures, especially in our patients who are already vulnerable to seizure risks. You have to be extra careful. Like I said earlier, is always weighing risk and benefit. It's never absolute no. You have to collaborate with a specialist, let's say neurologist, for instance, if there's seizure risks. And there's also risk of paradoxical activation, has to do with the serotonin pathway. This is actually a very common paradoxical reaction in our neurodevelopmental population in general. Again, it doesn't, prevent it, but, you should have to be careful. Buspirone is a reasonable consideration for as an alternative treatment for anxiety. This is a rather much gentler medication compared to SSRIs. I remind families whenever medication is known to be gentler, its effects may also be gentler. It's always double-edged sword. And generally speaking, it's much better tolerated. No dependency, no sedation, lower risk of seizures than SSRIs. It's one of my favorite to go to for younger child, especially with a higher risk of paradoxical activation. We briefly touched on benzodiazepine, maybe whether quick and strong anxiolytic, but does carry a risk of paradoxical disinhibition. Basically, almost like relax them too much, right? They lose the inhibitory control. It can sedate them, it can cause cognitive dulling, dependency withdrawal, but it's often one of the popular rescue medication options we talk about, especially families say, I need to take my child into blood work, flight, family wedding, we always bring this up. One of the huge benefits is that it's strong, it's usually very quick to act, and besides all the potential adverse effects we just talked about, it's fairly safe. In terms of the seizure risk too, a lot of seizure patients keep it as their seizure rescue. So if I'm have to choose something and I don't want to worry about the seizure risk, and this could be one good medicine. But the reason why we don't usually use it, or we don't often use it as a regular medication, is that it's a habit forming. So if you use it every single day, every day, it's likely going to lose the effects, and it may build tolerance and increase risk of withdrawal. Irritability aggression is probably one of the most common presenting challenges to bring them to psychiatry. I also call it emotional behavioral dysregulation. It's really more of a regulatory problem. We all get frustrated, we all get anxious, we all get sad, but our children and families with CDD, they lack in the regulatory control, and often the range of emotional or behavioral expression can be overwhelming. And then it doesn't feel right even to the patients, and obviously it brings up a lot of safety concerns for the families as well. We do consider antipsychotics, risperidone or Abilify. Those two are actually FDA approved for irritability treatment in patients with autism. We don't have data for CDD. Again, if the CDD patients have comorbid autism, then it may help give us more a reason to try it. I often reserve it for severe irritability aggression, but if there's any concern of safety, for instance, they're hitting themselves severely or hitting caregivers, then I really would consider it. It does have significant side effects, especially long-term, like weight gain, sedation, abnormal movements, like a Parkinsonian symptoms, rigidity, prolactin increase. But again, like I always remind the family, this is a strong medication. Strong medication often comes with a strong, array of side effect profiles. It shouldn't automatically exclude it. If you have a risk and benefit ratio in favor, you should consider it. And the anticonvulsants, like anti-seizure medicine, generally it's been sort of an easy access, in terms of how a lot of us historically have felt like this is very helpful. But unfortunately, the studies have not been very supportive of the efficacy or effectiveness of anti-seizure medicine as a behavioral medication or behavioral regulatory medicines. But again, story is different. I mean, if your child has active seizures, and then again, like I said, I would always recommend let's address the seizures first, because you can't really say that the seizure is not underlying the behavioral challenge, right? Lithium, again, is a scary name to many families, but some of my patients are on lithium. Generally, in our NDD populations, lithium is a very strong medication with strong possible side effects, also strong effectiveness, But because of the needs for frequent blood work and monitoring parameters, etc., it's not one of those medicine I go to as a first line. But if we tried other things and the child doesn't respond, then lithium can be a game changer. So I just want you to remember the name, not that it's a medicine for everybody. And for ADHD, like we just touched on briefly, if I have a child with ADHD, regardless of any developmental disorders, I would always make sure they don't have any particular medical comorbidities to preclude them from medication trials because medications for ADHD include like stimulants, which can increase risk of seizures. Alpha-2 agonists, clonidine, guanfacine, could also increase risk of seizure, although it's much less. Atomoxetine or Strattera in brand name can also increase the risk of seizures. So almost in every medicine in psychiatry, unfortunately, except for benzodiazepine, may have some sort of risk. Maybe I shouldn't say every, but there's a lot of medicine in psychiatry that may have risk of seizures. But, don't be scared. Again, it's always relative. It's always risk and benefit ratio, all right? So let's say your child has ADHD. Stimulants are generally the number one as most effective. But like I said, when it's most effective, you might also expect more side effects. But generally, stimulants or alpha-2 agonists are well tolerated. If a child has pre-existing anxiety, sometimes stimulants can make it worse. But at the same time, it can be the opposite. Like if a child has a lot of anxiety, it's hard for them to regulate their emotions. Stimulant treatment or ADHD treatment actually can make it better. So ADHD is often misunderstood as an academic disorder, but it's actually more of a regulatory disorder. So, we can see that people with ADHD have a very hard time regulating their feelings, their thoughts, and, you can expect them why many of them have like anxiety, So oftentimes when we help them regulate their, attention or mood or whatnot, they feel better and they behave better. So actually, ADHD is one of the first things we try to rule in or out when we have a kid presenting with behavioral concerns, because ADHD was one of the most common disorder that we see in child psychiatry, and one of the most common reasons for aggression as well. Insomnia, like we touched on, and I'm not going to spend too much time on this because I know there's a session specifically dedicated to this. Again, no CDC-specific pharmaco trials exist, but we know from other use cases there's many medications. One thing to note is that generally speaking, there's no medicine or psychiatry together to treat the maintenance of the sleep. All sleep aids are basically built to sedate them enough to go to sleep or kind of reset the sleep cycle. So no medicine in general is designed or is shown to fix the waking up in the middle of the night, unfortunately. So melatonin is a popular one, over the counter. Clonidine, trazodone, as you all heard about. Gabapentin is anti-seizure medicine we often use for sleep. Antihistamine like Benadryl can also be a nice one. But the reason why I emphasize what I just did, so most of the sleep aids, from my understanding, is that they cause some sort of sedation or calming down effect and make them go to sleep. Like I said, exception would be melatonin. It kind of helps reset the time, the chronotropic medicine, which means that if you give too much, let's say sometimes too much to make them go to sleep or keep them asleep, they could actually wake up very tired. So it could be a vicious cycle. Like we call it grogginess, right? They sleep through the night, 10 hours, wake up very groggy, and it's another vicious cycle, right? So you really have to balance, right? But the balance equation doesn't only include the child or the patient. It also should include the parent. I have a kid who's like 20-something. Again, he's not on the CDD profile, but he's on the autism profile. He doesn't sleep through the night. He always sleeps a little later, and some part of the year he ends up going to sleep at 1 p.m. and wake up 1 a.m. And I worry more about the mom, who's elderly, who's not getting enough sleep, So you have to really include everyone, especially the caregiver, in terms of building a good sleep regimen. Stereotypies, again, this is a really common question. Do we treat the stereotypies, like stimming or whatnot, right? First answer is don't treat it. A lot of times it's a functional for the child. They do this to calm themselves. A lot of it is soothing. Of course, you have to rule out like OCD. Is it some sort of compulsive behavior that we should actually treat to reduce? No, if it's not compulsive, it's rather soothing, like sort of functional behavior they need to do, then sometimes forcefully removing it causes more harm, right? And also, hey, sometimes it may look concerning, but for the child, for the individual, it may not be of a concern. So I usually don't target it. Of course, the exceptions are if the stereotypic behavior is actually self-harming, let's say, they actually do bang their head, hit their head, and we do worry about them getting physical injury, then, it's a different case, right? So really assess the functional aspects of that first, rather than just the look of it, okay? Let's see. Okay, so this is a wrap up. So we talked about how behavioral challenges are very common, which is one of the main reasons for burnout for both the patient and the families. And then, we can consider, you always want to make sure you rule out medical etiologies, communication, stressors, other things. And I almost always remind families that psychiatric diagnosis sort of have to be the diagnosis of exclusion. After you've kind of known, make sure that everything else is kind of like excluded. Optimize behavioral support and communication. And when you consider medicine, you want to be very careful, balance the risk and benefit. A medicine with a hard array of side effects doesn't automatically get excluded. You just have to be aware of the balance risk and benefit ratio. Okay? Thank you. Any questions? That's a good question. So the buspirone is meant to be taken twice a day, if not 3 times a day. It's a relatively short half-life, and it's something that has to kind of build a level like SSRIs. So you need to give it. As you know, a lot of times when you give it more than twice a day, the compliance rate drops significantly. So I try not to give more than twice a day, although ideally it may help with a more steady therapeutic level. And actually, a piggyback on this is that if it's a daily medicine like SSRI, for instance, like Prozac, I would often consider splitting it into twice a day for our patients. It kind of goes with the principle I try to minimize the side effects. If it's like 10 milligram a day, in theory, if I give it 5 milligram twice a day, they may still reach the therapeutic level similarly, but the peak may be lesser, so they will likely tolerate it better. But of course, you have to kind of fight with the insurance. Sometimes they don't want to give it more than twice a day. Yeah.
In the non-medical therapies for behaviors, there was no mention of diet or supplementation or allergies or anything like that. I just wondered if you had is that not part of what caregivers had unless they're
Comment on the ketogenic?
I think in terms of supplement and diet, to start off with like supplements, sometimes you would use like magnesium to help them relax, help them. Some people will report that it makes them like sleep better. There's some. When I think about supplements, I think of it as like something that you can buy online over the counter without a prescription. Those are like not regulated. Those are probably not as rigorously studied, and then also probably not as effective as a prescription medication, but also not probably better tolerated, probably less side effects. So sometimes we may use what's called N-acetylcysteine. NAC is like in the hospital, they will use it as like a Tylenol toxicity antidote, but there's some small literature on how it can be helpful with it's in like hair pickings, skin picking, hair pulling, nail biting, and some like anxiety component. Using NAC could be helpful. And then ketogenic diet, it is something, at least in our institution in Boston Children's Hospital, the primary indication is epilepsy. But when we use the ketogenic diet for epilepsy, which many children with a CDD have, we do see sometimes we do see improvement in alertness, mood, and sleep issues. We may sometimes do that, but the primary indication to start ketogenic diet will be to better control epilepsy with the behavioral mood as like a secondary gain.
I just want to add that our omission of that topic is not an indication of our no appreciation. Generally speaking, the diet is very hard to control and hard to study. But I have to tell you that I have one family with a child, adult child, who has a very significant GI issues, and the family has done everything in dietary modification possible to really improve. And so the one particular challenge for this child is the mouth dryness. So their diet, for instance, would really focus on keeping our mouth dry, mouth somewhat moist and hydrated. I'm usually very, very open to family, suggestions or tryings, different things. Of course, if I hear anything a little bit concerning, we'll review the evidence together, and I always more worry about the lack of evidence, like just the way I approach the medications, because a lot of times that over-the-counter or herbal or the dietary modifications, we may not be aware of the potential harms. Because it's not easy to be measured. I try to be careful, but again, at the same time, I appreciate sort of individualized attempt. Yeah.
What type of magnesium? What type of magnesium are you talking about? You mentioned magnesium.
Magnesium, yeah.
Yeah. What type of it?
What type of magnesium? So magnesium come in various salts, like oxidate, carbonate, glycinate. The magnesium is important to note. The magnesium can help sleep some cases, but it's not very strong. It can also make them feel a little bit relaxed, some family report, but again, it's also not, I always caution, again, magnesium can be toxic if you take too much of it. Of course, it takes a lot of it, but it's over the counter doesn't mean that it's naturally safe. Even water can be toxic if you drink too much. So I always ask family to be careful. And also, I learned this through family, which is again another humbling experience, that there's some forms of magnesium, like magnesium glycinate, I believe, is a little less laxative. So magnesium in general is a laxative. So sometimes family oh yeah, let's make our kids go to sleep, and they end up having a lot of diarrhea. So you want to be careful. But certain magnesium salts may be a little less laxative. But sometimes you can use this side effect for its benefit, right? Let's say my child is constipated and not sleeping. Hey, that's a perfect, solution, right? Yeah.
Which one would you use for that solution?
You mean like the which salt? I usually don't have any, choice, but sometimes I collaborate with the GI because again, this is beyond my scope, so I'm not going to give you specific names. But I know certain salts are a little bit more known to cause like rebound, like the acidic problems. They're supposed to sometimes help with the reflux, but I heard from a GI doctor, I forgot which salt. Sorry, but so they're known to cause rebound, and also can be learned through experience. So I'll defer it to those folks. Yeah, but the key point is that there are various salts, and they may have a little different properties across, right? And also don't overuse it. Okay. Yeah. Yes, please.
Two are really easy questions. You were saying about sleep and having a quiet, dark room. What's the thought on the sound machine? Is that advised against, or would that be acceptable?
So
I think in terms of sound machine, I think that's a reasonable way to turn it on before they go to sleep and keep it on. So I don't have any objection for sound machine. I may have a little bit of a split in opinion about some night lamp. And I think a little bit of gentle lighting at nighttime can be helpful, especially if they are afraid of dark. Certainly, you don't want to make it too bright because it can suppress your own melatonin. And then the thing about night lamp is if things get turned off in the middle of the night, then if your child wakes up in the middle of the night and then notice that the light is out, then they are recognizing the environment has changed. So could that potentially trigger them to come into full arousal, recognizing that the environment has changed? But to answer your question, I think overall the thought is that the sound machine is okay and it can be beneficial.
In terms of CDKL5, what is that we should kind of expect while they are growing up in terms of psychology or psychiatric changes? What do we expect during their lifetime?
I'm afraid that we really don't have a common answer. It really depends on the cases that break out with a major psychiatric disorder later in life. Major psychiatric disorder later in life versus earlier. So it really depends. But I would always remind families that data collection is the key. The chain longitudinal data.
I have a question because when it's very obvious that the kid is not doing well, you really need to help him or her with a drug. But is there any rule of thumb or when, as parents, when should we consider that might be the time, to go see a psychiatrist and see, okay, maybe she needs some extra help?
Yeah.
Like, I'm not there yet. My daughter is just 3 years old. I don't see anything big, but I do see that she's starting having, character. So, yeah.
Yeah, it's a great question. Actually, I'm so glad you brought it up because one of the things we wanted to share is how we collaborate with other providers, and I think is related. So a lot of family enter medicine through different specialists. Sometimes neurology, sometimes developmental pediatrician, sometimes psychiatry, right? And when is the time we need to see a psychiatrist? I don't think it's a straightforward answer, of course. It depends on the family, it depends on, the capacity or the scope of the other specialties they're seeing. But I'll say, generally speaking, if certain behavior is really causing significant functional impairment. Functional impairment is a very important term in psychiatry because, no matter how low or high the burden of certain, abnormal thoughts or feelings or behaviors, the level of functional impairment is really what's more important, because every family has a different level of, capacity to compensate. Again, I'm not being judgmental. I mean, it could be like if you have 5 other children, it's a lot harder, right? Say if you have 5 other extra family members, it's a lot easier, right? So I really try to meet where the family is, but if a family, like a caregiver, is really feeling is causing like significant impairments in our family. For instance, it could be, hey, since last year, my child just can't stay in the class, for instance, right? Or can't stay in the training, then we all can start to worry, oh, he's losing or she's losing so much from that given training, right? Sometimes it could be even easier or relatively more common scenario. Let's say, oh, my child doesn't have any behavioral challenges, but he has severe ADHD, let's say, and then won't listen to anything in a given class. And I start to worry, oh, then he's only losing so much, right? Missing out so much, right? Then it could be a good reason to pursue medication. So sometimes it doesn't even have to be like a very serious behavioral challenge, but in a given setting, as you know, it's so important for our children to keep up with the given training and education. If that's being impaired, and again, I don't think anybody has a reason to judge. If a caregiver is really feel there's a concern, I think we should listen. But I'm gonna be humble again. Like, not everybody has the luxury or the access to see a psychiatrist or let alone specialist. So that's why I said, first step is to really work with one you have and kind of discuss the next levels and kind of seek out the treatments. Thank you for the question.